Hello, everyone. Welcome to this next webinar of LTC COVID. Today, we're going to have presentation on reopening care homes to family and other visitors. And I'm absolutely delighted to have as speakers Lee-Fay Low from Sydney. We've got Kathryn Hinsliff from the UK, and we've got Hilde Verbeek from the Netherlands. And I'd like to ask you all to please mute your microphone if you're not when you're not speaking. We're going to have a format where we first have an hour of presentations, and then we will have half an hour of discussion. If you think of any questions while you're hearing the presentations, feel free to write them in the chat box. I'll be monitoring that, and I will then be moderating the discussion and make sure that any questions are picked up, even if you're not able to then follow it up. You will see that we are recording this webinar, by the way. So if you do participate in any way, please be mindful of that. We will be making the video available through the LTC COVID website, and also we will also be making available the slides. So thank you, everybody, and please, Lee-Fay, feel free to start. Thank you.
So good evening, everyone. Just so you know, I'm from Sydney, Australia, where it's about 11 p.m. here, and we're still keeping our social distance, though perhaps not as strictly as we were early in COVID. So to remind you, I guess, about the rationale behind care home lockdowns and how long we've been locked down in some regions. Early on in the COVID outbreak, we realized that there were high mortality rates once COVID entered the nursing home. And so many governments restricted visitors, including family visitors, to nursing homes very early. So the Centers for Medicare and Medicaid guidance came out in March, mid-March. So as I said, once it goes into a home, it's hard to prevent spread, and we know that the care home fatality rates are between 0 and probably a third, depending on how well controlled it is and treated it is. So from the LTC COVID work, we can see that hundreds of thousands of residents have died in care homes, and that care home deaths can account for up to 80% of all mortality, for example, in the Canadian data. And in this context, I guess, you might be familiar with the COVID tracker stringency index. And I've just set the date ranges from the 1st of March to the 1st of July here. And to interpret the stringency index, which graphs, I guess, the strictness of the government response, it goes from kind of very pale blue through to dark blue through to red being the most stringent response. So here in the 1st of March, you can see the first few countries where COVID occurred in China, Italy, for example, with high stringency. And you can see over time here, as more countries start to go into lockdown, you see darker and darker colors happening. It's about here that care homes start looking down, and they stay locked down. You can see the colors going more into the reds as lockdown becomes more stringent in many countries through April, May, and June. Here we are. And then you'll see that the colors start to lighten around June as stringency eases, I guess, as countries stop locking down. And then, as we've been seeing in the last few weeks of June, we start to see lockdowns happening again. So that's, I guess, the context in which care home reopening has been happening, that we've seen care homes starting to reopen in June, and we've got to think about what's happening with lockdowns starting to happen again in some areas at least. So we don't have great data about what's been happening in lockdown facilities, but we've seen these anecdotal reports of residents being lonely. So to my wife, I miss you more than everything. I miss all my girls, and this really cute lady who says, please call a large pizza. Lovely stories on Facebook. Miss Lenora would just like to receive some mail. So kind of these heartbreaking stories, anecdotally at least. We still don't have great data about residents being lonely, feeling isolated, and some case stories, I think, of, you know, agitation in people with dementia. So there's this really tricky balance that we're trying to strike in reopening care homes between well-being of residents, but safety of residents. So I'm just going to run you through the American guidelines, knowing that the other speakers are from Netherlands and the UK. This is what their guidelines were. So each state was to determine the criteria for reopening, but based on the following factors: case status in community. So state-based criteria to determine the level of community transmission and guides progression from one space to another. So they were really looking for a decline in number of new cases, hospitalizations, or death. And this, to me, always has felt problematic. So the new cases, which is, you know, incidence of COVID, compared to, isn't correlated at all to prevalence. So those epidemiologists amongst you will be very familiar with the idea that the incidence, the new cases of COVID is the amount of water going into the bath, and we could turn that tap off a little bit so there's less and less cases going in. But that doesn't really correlate to the amount of COVID in the bath, the prevalence. And that's changing slowly depending on who's died or who's got better. But we could have turned off that tap completely and still have lots of COVID in the bath. And that's why I'm of concern, I guess, when we talk about lifting restrictions or easing, or, you know, allowing visitors in without considering the community prevalence of COVID, just the incidence. So besides that, in the CMS guidelines, the nursing home has to be COVID-free. It's got to have enough staffing. It's got to have access to adequate testing, meaning can test all residents and staff and have relationships with labs so we can get the results rapidly. It should have universal source control, so ability to get masks, and have visitors maintain social distancing, hand washing, sanitizing, adequate access to PPE for staff. And also, interestingly, the local hospital capacity was a consideration. So whether the local hospital, if there was an outbreak, could accept transfers from its nursing homes to help control the outbreak in that facility, which we know it is one way of managing outbreaks in facilities. So visitors were to be permitted within the CMS guidelines. It's linked to stage 3, phase 3 of, you know, opening up America again. And once visitors were allowed in, all facilities, visitors had to be screened, temperature, and signs and symptoms of illness. And during visits, visitors have to practice social distancing, hand hygiene, and wear masks. 26, so this review, you know, shows that 26 states have issued additional guidance, some of them with additional requirements beyond the CMS, including that residents and visitors have not been tested positive for COVID and not showing symptoms. Some say only outdoor visiting. Visitors are limited in number, typically 2 or fewer, and visits must be scheduled in advance. Restrict visitors by age, so have to be 12 or older. Visitors should wear PPE, and residents should wear masks tolerated for the duration of the visit. And facilities should be setting up and managing a schedule for visiting, so they should know who's coming and when. They can limit the number of visitors. They need to provide the space and the PPE and hand sanitizing equipment. The outdoor space should be accessible without having to enter indoor areas. They need to have trained staff in COVID infection control to help the residents to and from the space and to observe the visit while keeping it confidential. They need to clean the space between visits. And I thought it would be interesting to look at what's happened in the first state to resume nursing home visits, which was Massachusetts on the 3rd of June. So for context, you can see that on the 3rd of June, the number of new cases, hospital cases, and hospitals using surge capacity were coming down over time across May into June. when visitors went back into care homes, they had 429 new cases that day, about 100,000 total cases. And again, more context, the population of Massachusetts is just under 7 million people. So when visitors started going back to care homes, they had 350 long-term care facilities with at least one probable or confirmed case of COVID. As of yesterday, they had 369 care homes. So in that 1 month where visitors were going in, they had 19 new facilities with at least one case. So not that many relative to the number of cases they had before. So I guess this is in the context of that not being a second spike at the moment in Massachusetts, from what I could see from their data, but that these second spikes are happening in other places, with quarantines reimposed in lots of places, including California, in Leicester, and I just want to share, I guess, our experience here in Australia. So we never had a complete visitor ban instituted by the government, but aged care facilities ban visitors, kind of reopening up around Mother's Day weekend in Australia, which is about around the 9th to 10th of May. Since then, we've had no COVID transmissions through visitors, though I should say as context that we've got very low community prevalence of COVID completely at all. There has been a great deal of variability in how care homes are reopening in terms of window visits, inside visits, and how other non-family visitors have been allowed in, including hairdressers, entertainers, and other non-essential personnel. And so even though we have some industry codes of conduct, it seems like facilities are just choosing to do whatever they think best. And I don't know if that's grounded in best practice or data. So for instance, I'm hearing about hairdressers serving several facilities, and that's quite an intimate kind of job. So the Australian not-for-profit providers and peak advocacy bodies put together an industry code. So quite different from a government code for visitation. This was one made by industry and consumers. It was released on 14th of May. So shortly after visitors started going back in, and it's been updated just recently. The point of the code was to provide an agreed industry approach to ensure aged care residents are provided the opportunity to receive visitors during the pandemic, while minimizing its risk of its introduction or spread within a care home. What's interesting in this code compared to the other guidelines and codes I've read, including those from England, Wales, Scotland, Ireland, is that our code explicitly states the rights of residents and visits to get information about what's happening in the home, to maintain contact with their local community, including participating in religious and cultural gatherings via Windows or Zoom or similar. And also it explicitly states that they have a right to be provided with additional ways to connect, such as window contacts, video conferences, or phone calls. And that there's a responsibility of both residents and visitors to follow infection control. What's also seems to be unique in our code is that it mentions that external outings and small family visits, so going out to visit family, are permitted for residents and visitors where these can be conducted in a safe manner, and then sets out some of the procedures that need to be done for this to happen. I haven't seen this happen anywhere else. Remember in the context that until recently, we've had very low prevalence of COVID in the community here in Australia. Our code also sets out a complaints process that firstly, they should talk, the resident visitor talks to the facility first, including making a formal complaint to the facility. Then they should talk to the Older Persons Advocacy Network, which is a government-funded network of organizations which can help older people and their families complain, I guess, or get support in negotiating with their nursing home, their aged care facility, before making a formal complaint to our accreditation body, the Aged Care Quality and Safety Commission. also very interesting is that our Department of Health endorsed the code, so it's been promoting it on its website and has translated into several languages. But our accreditation body has also promoted the code and has said that it will use the code as a clarification of expectations for what quality care might look like at this time. And so they're going to use the code as part of their monitoring assessment. And I think that's really interesting. We've never seen this in Australia before, that the Quality and Safety Commission is using something that industry's provided as to help them with their standards. But it's, where everyone's hopping in the run, and I think at least it provides clarity about what the expectation for quality care is at this time. So as of today, we have a second spike in Victoria at least, and we're seeing nursing homes shut down again. They've locked down a whole lot of postcodes in Melbourne, including complete lockdown of several housing commissions. So I don't know what you call it, pension housing towers completely locked down with 500 police. I don't think it's being handled very well. And all the care homes, pretty much, from what I can tell, in those postcodes have been closed to visitors. So there's many questions, I guess, and unresolved issues that I have. I still don't know when a facility should deem that outdoor visits are safe, indoor visits are safe, but I think that it should take into account community prevalence of COVID as well as the new cases. There seems to be unclear how facilities define COVID-free before visits can happen. So 14 days since the last positive test, do you have to get negative tests? I don't know. How similarly residents are defined as COVID-free. I guess it really depends on how available tests are in that region, whether you can wait for 2 negative tests or 1 negative test. I'm concerned, I guess, about quality during visitor restrictions. So the CMS guidelines suggest that regular recertification inspections of facilities start during phase 3 of reopening, which has happened in some states, but if there's re-lockdown, then they'll stop again. And they'll only do inspections if there's, kind of a need that someone's in jeopardy. Wearing of masks. This is controversial here in Australia, where our government hasn't mandated or isn't even supporting wearing masks very strongly. Is this essential for visitors, indoors or outdoors? Essential for residents? What type of mask and who provides the mask? And how do we ensure that the mask is worn correctly and safely? And I've also been thinking about outdoor visits in winter. We've seen some locations starting to think about building new structures for outdoor visits as the European and Northern American winters, we're heading into that season now. I still am so concerned about how these are being funded. I know from our local facilities that it takes 2 staff members to support a safe visit for 1 person. So one staff member screens the visitor, takes them out, walks them around safely to the outside area. The other staff member goes and gets the resident, gets them ready, brings them to the area, and then one person who's observed, the next person runs and gets another person. Well, that's 2 staff members off the floor who would have been doing other things like engaging residents. Often here it's the lifestyle staff who have been doing these jobs. It could be anyone, but it's 2 people off the floor who had other jobs to do. And I don't see more money being put in to fund this. I always like to show these next slides. This is the Outside In Collective, a group of engagement specialists I've been working with here in Australia, and we've been trying to make sure that we visit residents from outside and play and have fun and entertain and connect with them. And some of these residents who we visit, they don't have family visitors. So even if visits were allowed, it wouldn't be possible. So this is a beautiful story of this lady, and she sees the other residents, being taken out for their visits every day, and she knows that no one's going to come for her because no one comes to visit her except our engagement specialists. So there's lots of, I think, connections that happen that residents are missing out, which aren't just about family. It's about group bonding and, you know, and having fun and that different type of meaning or connection. And I guess my final kind of comment before Adelina throws me out is that in these discussions today, the resident voice is almost completely missing. So we don't really hear from what residents are experiencing or what they want or what would help them in terms of connecting, except for, you know, finding things like this on Facebook or in the newspaper. And I will stop there.
Thank you very much, and well preempted, Lee-Fay. I was just about to call you up. So next we're going to have a perspective from Kathryn Hinsliff and some new research that's starting in the UK. Floor is yours, Kathryn.
Thank you, Adelina.
See if you can share.
Yes, let's see if we can do the first thing first, so that'll be a good step. Hopefully you can all see that.
Yeah, perfect.
Okay. So good afternoon or good morning or good evening. I know we've got lots of international people that have logged on. So here in the UK, it's the afternoon. So I'll just say good afternoon as a broad welcome. Thank you very much to Adelina for organising this webinar and for the opportunity to share the work that we've been doing and some own perspectives about what's happening within the UK. Some of the views that I'm going to share are my own personal views, but also what's being gathered in the evidence. So first of all, just a little bit of background about myself. I'm Kathryn Hinsliff-Smith. I'm a senior research fellow at a university within the UK, Montfort University. And most of my research background is being involved in two main strands of area. One being the health and well-being of older people, with a particular focus on care homes, but actually in some ways aligned around gender-based violence and domestic violence. So those are two of the main key areas that I'm particularly interested in and what most of my research is being conducted around. And obviously today I'm going to talk about the perspectives around care homes. I've also been fortunate that I've worked on a number of studies, some particular ones in the UK, a large piece of work called Peach, which involved care homes and 4 clinical commissioning areas. So a large number of care homes in terms of looking at quality interventions, QI measures, to look at different ways of supporting and health and well-being of older residents or any residents within care home settings. And I've been fortunate enough to work, some of the work that I will share relates to work that I've done with colleagues in Brazil. And I know I've got some Brazilian colleagues on the line today, so hello. And also some work in South Africa as well. So the study, I need to just click along. Okay, so this is the study that I'm going to share some preliminary themes around. This study, and I'll talk about how this study came around a little bit later on, but predominantly it's around family carers. And I know that the previous speaker, Faye, mentioned about residents are often missing, their voice is missing. Well, from our perspective, what's missing here is also the relatives, those people that would normally see their relatives who are residents in a care home on a regular basis. And although there's been a lot of work done within the UK and overseas around care homes and the situation they find themselves in, often what's missing is the perspectives of the relatives, those people that are no longer able, due to the pandemic, to visit their loved ones. So what I want to do is to just in this 15 minutes before Adelina cuts me off is just share three real aspects, just to give you an overview about care homes in the UK. I'm aware that we do have a range of people that have dialed in and will be listening to this later on. Also about the actual study and how it came to be, but also just to share with you some preliminary, and it is very preliminary, and you'll see why shortly, some of the themes that have been coming up, which I'd be really welcome to share, and also to hear about whether that relates to other instances in your own settings. So just to give you some context, like most countries, most Western countries, the UK has very much an ageing population, and we're aware that people are living longer than what they used to do. And we know there's a whole range of reasons why that occurs. Within the UK, we're just over 15 million people over the age of 60. And I know people that are getting to that age would say, crikey, I don't see myself as being old because I'm 60, but it is one of our catch times when we catch that number of people over 60, usually around retirement age within the UK, around 65, although that's increasing as things change. But basically a large number, 23% of our population, are over the age of 60. And I know that may be similar in some of the other settings that people are aware of. But we've also got an older age population, those over 80 and 90. And in fact, when I was working on the Peach study, I had quite a number of residents who were over the age of 100. And that's becoming less and less or more common, should I say. But of course, we're also aware that actually this age range is the one that is actually going to exponentially increase. And I know in comparison to other countries like Brazil, my colleagues in Brazil are aware that this is a similar phenomenon that's occurring there as well. So we have got ageing population, and we're likely to see more people of that age. And in terms of when we think about our care homes, and I'm using the term care homes here in the sense of a broad generic term. So that's residential, with or without nursing care, but it's where someone will live permanently. So it's a care home facility. And in the UK, there's approximately, and again, you see different figures, but we'll use this one for today, around 450,000 people live in these long-term care residential settings within the UK. And just give you a context of that, that's around 3 times more than what we have acute beds within hospitals. And I want you to bear that in mind when we come to look about what happened in the UK in terms of the lockdown and the messaging around to protect the NHS, because I think this is actually quite key. We are also aware that within our care homes within the UK, we are aware that most of them have got some form of cognitive impairment, particularly those that are getting older. So cognitive impairment, dementia, Alzheimer's, etc. is much more prevalent, as well as other comorbidities. So we're aware that there's polypharmacy needs within care homes, so people that are on more than 4 medications, certainly different types of comorbidities as well exist, but also we're aware that actually more and more people are likely to be diagnosed, and that will obviously impact of those numbers that are living then within care homes or need that additional support within a care home setting. Just to give you a context within the UK, and I know that some of you may not be familiar with this, and this is really just to give you a view of, because there are differences between the UK and other countries, for example, that we work with over in Europe, say in Holland, for example. But predominantly, care home provision in the UK is privately owned. And it's operated by companies, chains of, they may have 2 or 3 care homes. It might be private individuals. Care homes can range from as small as I had a 4-bedded care home in the study that I was working on, the Peach study, all the way up to 100, 120 residents. So a real range of different types of provision. Some of them may be run by local charities or religious organisations, and very few in the UK, certainly within England anyway, are run by what we call local authorities. In other words, local care provision, where they're all run to the same standard. We don't have that within the UK no longer. And the other key thing is that actually care homes are not funded from our National Health Service, the NHS. It's actually funded from a different pot of money, if you like, social care provision. And again, that's key when we talk about the lockdown and the provision of protecting the NHS and the funds provided for healthcare. A lot of our residents may require nursing and healthcare as well as social care. So there's a real mixture of the types of residents and how they're being funded and what their needs are within our care home sector in the UK. And also, as well as being funded differently, we may find that actually our residents themselves are actually funding themselves. And we have a system in the UK based on your assets will depend on whether you have to contribute to your cost of living in a care home. We could talk about this for hours, but we're not going to. We have a short window here, and I want to talk about the actual study itself. And just finally, we have about 19,000 independently care homes in the UK. So you can imagine a large sector, lots of residents, funded very differently, and we've got an ageing population within the care homes themselves. So just stepping back, and it doesn't seem that long ago that we were all working in our offices and not seeing each other's lounges or studies or wherever else we're dialing in from at the moment. So we were aware that in January, obviously the WHO declared that actually, obviously we were aware from Wuhan of the pandemic. We all certainly know the terms COVID-19 and coronavirus now, but on the 11th of March, it was classed as a pandemic. And within the UK, because I'm going to just talk about the UK context here, on the 23rd of March, we went into a national lockdown. And the key terms here was to stay at home, protect the NHS and save lives. And that date is fundamental, I'm sure, is in most of our minds, because that's when we went into a total shutdown. People were encouraged to work from home if possible, but certainly we were not going out anywhere. Also, prior to that, however, on the 17th of March, the NHS had actually wrote to all the trusts, so the healthcare trusts within the UK, aware that obviously we were likely to see more numbers, so they actually had to expand their critical care capacity, which basically means we need to release beds. And the output of that is that actually we had a number of acutely ill people through various things, various reasons, were moved into care homes. And again, that's quite a fundamental shift, and I'm sure that in years to come we'll be reviewing that decision as it is. It's not my place today, but just to give you that context of that was occurring within our care home sector. So we then became very familiar with these. Playgrounds were completely shut. We suddenly all began to love our NHS again and realise the hard work that was being done by healthcare professionals. But certainly we were on a total lockdown. We were encouraged to work from home if possible, and we had special Nightingale hospitals put into place. What's missing from here is any mention of care homes. Care homes didn't seem to figure in this because it's all about the NHS. And to most people, the NHS, the person on the street, Joe Public, if you like, the NHS is the hospitals, the GP, the local services. It certainly wasn't care homes. So it really didn't factor within any of the discussion, or certainly within any of the media. And certainly within our daily bulletins, our death rates were being reported, but actually weren't including death rates within communities, and certainly not within care homes. And so there was quite a lag of actually recording that actually people within care homes were also dying as a result of the virus. Adelina, I'm sure you're going to give me a heads up. I have started my stopwatch, but I'm sure you're going to give me a heads up when we get to the time. Okay,
we've got 7 minutes left.
Fine, no problem at all. Okay, thank you. So in terms of where we are in the current picture, and this is as of 2 days ago, yeah, a day ago even rather. So the current picture, you can see the number of cases that we've got reported, but also the rising number of deaths. And again, who would have thought that, you know, some 15 weeks ago, we'd be actually reporting that number of deaths within the UK. And within that, we're also aware ONS is our Office of National Statistics, where we record all our deaths, births, marriages, and other key statistical information, that we have had just over 19,000 care home residents that have been declared as dying from COVID. And what I would say there is that is where the death certificate actually identifies that they have died as a result of COVID. And I'm sure that we may have some discussion about there may be other people that perhaps also became deceased as a result of COVID, but it may have been declared something else on their death certificate. And I know there's a separate piece of work around how that's being recorded. But that just gives you a figure in terms of the number of deaths. And we're estimating that something like 1 in 5 care home residents are infected with the virus. Not necessarily that that will see their demise, but certainly that they may have been infected, and that obviously puts an additional pressure on staff within care home settings. And just finally on here, before we get on to look at the study, this is the number that have been registered. So the predominant main number of people that are dying from COVID are ones that are then admitted to hospital. However, I would say a caveat here that within the UK, we're not very good at tracking those residents and their status as in terms of coming from a care home. And we know that from our work on the Peach study, that we developed an algorithm so that we could track people that were from a care home who went into hospital. So I would surmise there that some of those deaths in hospital may actually be care home residents. Whereas what you've got here is those, the 29.7 are those that have occurred within a care home setting. So I would just throw that out there, that actually there may be some skew in there in terms of the figures, because we don't actually have a true picture of where they previously were occupants, i.e. a care home, private home, and their dwelling, etc. So care homes, I'm sure most of you are familiar with what care homes look like. They tend to be hubs of activity. They're accessible 24 hours to relatives to visit. Often they're seen as a place where people will go in freely. They don't make appointments. They go in and regularly see their relatives. And they may do a whole range of different activities when they go and see their relatives. And again, I've mentioned about the range of different types of care homes in terms of the number of people, but certainly that was the picture pre the 23rd of March, although some care homes in the UK did actually close their doors the week before, and we'll talk about that shortly. So where did this come about? Well, having conversations with a dear friend of mine whose relative was in a care home prior to COVID, it was really clear that actually she was experiencing quite a bit of distress, that she wasn't able to see her mother on a regular basis. And that got me thinking, as you do, those of us that are involved in research, our best research ideas come from having a cup of coffee with somebody or over the photocopier machine. This was, in my case, having a conversation with a dear friend who it was clear she was experiencing some distress, but concerned how she was going to see her mother again. We're on a national lockdown. What's that going to look like? And again, there was very little out there about the impact, very little in the press, very little from the care homes themselves, and very little in terms of, well, how does this impact upon us? So we're actually running a UK-wide qualitative empirical study, and we're interested predominantly in family carers. So those people that would normally visit their relative on a regular basis. And what I mean by that is not birthdays or Christmases or special occasions, but at least once a week, if not 3 times a month. And they would normally visit up until the date of shutdown. They'd see their relative on a regular basis. And we are actually conducting interviews with relatives about their experiences during the lockdown period. And then also once we get back to whatever we call normal, whatever that may look like. And so far we've recruited 15 family carers across the whole of the UK. So we're really getting some interesting perspectives from different people around the UK and different types of care homes as well. So, of course, this all happened overnight. In most cases, there was very little notice for relatives to prepare for this change of being able to see their relative in an open way. We're collecting evidence that's telling us that actually they had a phone call the afternoon, they're in the supermarket, they've got a phone call to say, after this evening, you won't be able to come and see your mother. So they dropped everything and rushed to see them in the care home. And that's a general picture. And this is not about criticising care homes, because they were forced in this situation as well, but just relaying to you that what the enormity of that situation can be, where you're used to going openly to see somebody and suddenly you're not allowed to do that anymore. So we started, we've got ethical approval for this, we started doing our recruitment, and to date we've already conducted 8 first interviews with our family carers, and we're constantly recruiting more family carers to wanting to share their experiences. So I want to share with you, because I'm conscious of time, some of the preliminary themes, and I'm calling them themes as opposed to findings because we're at a very early stage. But some work around, we've been collecting how they would normally visit their relative, and then moving on to what's been happening during the lockdown period itself. So if I can just go through those with you. It's very
You've got 1 minute, Kathryn.
Yeah, it's very clear that visits were constructed previously were very lengthy and regular. So people would go in for a couple of hours at a time on a regular basis, and they did lots of types of social activities. So not just come along and stay there and just sit and leave after 10 minutes, but also they do quite a lot of things, whether it be crosswords, reading the newspaper together, having food together, enjoying each other's company, a whole range of things. And we're getting that picture across the people that we've been interviewing. During the lockdown, technology, which we're all becoming familiar with nowadays, we would assume is quite obvious. But clearly that isn't as easy as it would sound in terms of getting your relative who may be over 80, maybe over 90, to suddenly do a Zoom or a WhatsApp with you. So I'm going to leave them images up there because I know that the complexities for us who we're supposed to be savvy with IT. Can you imagine you've got no time to prepare your relative for this? So this has been interesting in terms of this, and I'm happy to share some more information about this. Obviously, there's been an issue over time for people to prepare the care homes then to start seeing relatives coming in. That's been tricky in itself because they're having to do their day job of looking after residents and providing the care. In some cases, relatives have had to buy the necessary equipment to keep communicating with their resident, their relative. But we are seeing evidence that there's some restricted visits. Some are doing those indoors and some are outdoors, and some are not allowed any visits at all. So there's a real mixed picture here about what's happening within care homes themselves. And again, I'm hoping that as we collect more evidence as we go on, then obviously we'll be able to unpack that a little bit more. And I'm just about at the end. Obviously, there are some issues here for relatives because these are the sort of the headlines that they see on our daily media. The fact is, you know, this is a scary place for people to be living in care homes. You haven't seen your relative for the last 15 weeks. And in itself, that can create levels of anxiety, certainly feeling powerless and sense of loss because no longer have you can access it in a free way. You're relying on care home staff to mediate and allow you that access. But also we're picking up that actually it feels the same as it did when they were making decisions about putting their relative, and I use the word put because that's the term that's always often used, putting their relative into a care home. It feels like that all over again. I'm not taking responsibility. I can't get in. I can't care. I can't see that person. So there's a real sense of that responsibility again, and also when they might get to see them again, particularly as we're talking about older relatives and obviously end of life and the usual things that would happen when somebody gets to that stage in their life. I'll put the last slide up before Adelina tells me I have to stop. Okay, so just finally, in terms of where we go from here, it's absolutely clear that this is about a partnership between the care homes, the residents and relatives. And this is likely to occur again. We do have restricted access due to infection control within most care homes, regardless of the country. But if this continues to occur, or we have other things like SARS, etc., what will happen there? I am working in collaboration now with Hull University, who have got a national online survey, because we're aware that not everybody can spare the time to do an interview. So I would encourage people to direct to that online survey. But clearly what we want to do is to develop some good practice guidelines to help care homes and relatives and residents, of course, to think about how best to keep communicated and keep those channels of communication open as we work through this, because certainly we're not at the end of this lockdown.
Thank you very much, Kathryn. Thank you. Feel free to share the link to your study through the chat, so people can also access it as we go along. So next presentation is going to be from Hilde Verbeek from the Department of Health Services Research at the Maastricht University. And I'm very happy to see you're already with sharing the screen. And please go ahead. Thank you.
Thank you. My name is Hilde Verbeek. I'm a professor of long-term care environments at Maastricht University. And today I will present about a study that we have conducted on allowing visitors back in a nursing home. And it has been published in JAMDA. I will focus on the results of this study, but also tell a little bit about a follow-up study we're conducting at the moment and we have done. And I would like to give credits to my co-authors as well. We did it from our Living Lab in Aging and Long-Term Care, and that is a collaboration between 7 long-term care organizations, Zuid University of Applied Sciences and also Maastricht University. And we did it also with our colleagues of Radboud University in Nijmegen. First, a little bit about COVID-19 in the Netherlands. So the Netherlands is a very small country, as you can see here in Europe, and the capital is Amsterdam. And the total number of COVID cases has been estimated of 50,000, a little bit over 50,000 in the Netherlands as a whole. And what we see, although we are a small country, we see quite a huge spread in regions. So COVID started in the end of February. The first cases came early March, and that was mainly in the southern part. So here you see a picture of March 30th, and all COVID related were mainly in this area. And we see the northern part, the northern regions of the Netherlands have relatively few infections, and that is still the case at the moment. So the northern part of the country has in general much less infections, but also much less infections in the nursing homes. So these are the numbers, so how it has grown over the time of COVID reported by our local health authority. So you see here an increasing bump. I think what other presenters has also shown, like the earliest of March, it goes through until April, and the end of April, early May, it started decreasing quite a lot. And what we see, and I've heard also other speakers say that almost half of the residents of the deaths in the Netherlands due to COVID live in nursing homes. So in total, over 6,000 people have died, whereas medically recorded that COVID was the cause of death. Of course, we can debate about that. And has been estimated that approximately over 2,500 have lived in nursing homes, to give you a little bit of background. So here you see a graph of the number of COVID nursing homes used with COVID. And here you see that it follows a similar process. So especially the end of February, early March, there was a huge increase in COVID related cases in nursing homes. And afterwards there was a decrease. And it is not officially recorded, the number of COVID cases in nursing homes. There have been set up several pilots using the electronic record files of putting it in. And based on these files by Verenzo, that is the professional organization of old age medicine, and there are, as the most recent estimation is that there are over 10,000 COVID cases in nursing homes. Almost 2,000 have died, and almost 2,700 have recovered from COVID living in the nursing home. And if I am speaking about nursing home, again, that is a broad term. So it could be a care home, assisted living, but these are all homes in which residents reside for 24 hours a day and where they receive care and support. But it can have various levels. To say a little bit about the nursing homes, they closed nationally on March 20th. So that means that our government, the Ministry of Health, Welfare and Sports, has decided that all nursing homes are banned for visitors. And we see that in the southern part of the Netherlands, this was already more than a week earlier. So from March 10th, many homes were closing by themselves because they were afraid and they couldn't guarantee the care. And they said, we're shutting it down for family members and volunteers and all these kind of visitors. And of course, the ban for visitors is a highly restrictive measure, and it has, of course, as already been talked about, an enormous impact on residents, but it also poses dilemmas for staff. And especially because staff quite feels, because they, I think around the same time, March 16th, the government said that all people from the Netherlands should work from home. Then the intelligent lockdown we had in the Netherlands went in. So people work from home, no travel, etc., etc. And then staff of nursing homes, they needed to come to work, but they were afraid, am I spreading the virus or not? What does it mean for my loved one who might be in a vulnerable position, and how do we deal with that? And they also saw the impact on the residents. There were, of course, creative alternatives. So, for example, as you see here, people on a constructor trying to visit, or here in a separate container. So some nursing homes provided separate containers, in which here you see there is a plexiglass or a glass with the microphone, so people could hear each other, in order to create solutions as alternatives for the ban for visitors. But still, I think it poses some serious challenges to the autonomy of residents and whether you can decide who you want to see or not. And as I think the previous speakers has already provided it, that the nursing home is also part of the community, and now you're shutting it really off. And we were interested because primary data on what does this mean, what is the impact on residents, is lacking. So together with the Ministry of Health, our Living Lab, the organizations, 2 months after the ban, the measures were taken to cautiously allowing visitors again. And this was started with a national pilot project that started on May 11th and in 26 nursing homes. So each local authority in the Netherlands, there are 25 regions, and each local authority was allowed to select one nursing home, which was allowed to, using the specific guideline, cautiously allowing visitors again. And they had to participate in our study because we were evaluating it, what that would mean in practice. And some specific guidelines were developed for allowing visitors. And I see some similarities which the previous presenters presented. The guideline, here you see the picture of it, was developed by stakeholders in the field. So that means that the professional organizations for old age medicine, the psychologists and the nurses were present. Client representative organization was present, who represented all client representatives for the nursing homes in the Netherlands, and the Alzheimer's Society, the Dutch Alzheimer's Society. And there was the ACTIS, that is the sector organization for nursing homes, so where all nursing homes could apply as the organization. They developed this guideline. The guideline is directive and not mandatory in the sense that there's no fine if you change regulations based on the guideline, for example, and it can be applied in the local context. And let me briefly state a little bit about these key points from the guidelines. So it has a section specifically for visitors. And that means that during the pilot period, only one designated visitor was allowed per resident. So each resident could choose one person who was allowed to visit during this person. And they need to take personal hygiene measures at entrance. So for example, sanitizing their hands. They make agreements with nursing home on the frequency and duration of the visits, and they are spread throughout the day and week. So not everybody can come at the time they want, but it should be in agreement with the nursing home. The visits take place at 5 feet distance, including from staff and other residents, and that is a similar national guideline, which is still in place in the Netherlands, so keep the physical distance. Visitors should be free from COVID-19 symptoms, and visitors are obliged to wear a protective mouth mask for visiting residents who are difficult to instruct. And so, for example, that could be people living with dementia, but not a general mouth mask, not for everybody. So what did the organization need to do? So they should observe the regulations from the guideline and keep perspective on the well-being. They should provide sufficient protective equipment. They do a thermometer assessment, so they should check the temperature for visitors while at entrance, and they have to provide sufficient applications for that. They have a strict hygiene protocol. They should have sufficient staffing, so a nursing home was only allowed to participate in this pilot project if they thought they had sufficient staffing and that was adequate level, and if there was sufficient test capacity by the local health authority. So in the Netherlands, the local health authority does all the testing for COVID for the general population, and especially at that time there was not enough test capacity for everybody, and so it was arranged that for these nursing homes who were participated, they had that full access. So this raised some research questions, I think, for knowledge development. So when we had our study had three major questions. So how are the guideline, the general national guideline, applied in the local context of these 26 nursing homes? How was the compliance in practice with the guidelines? And what is the impact on well-being, residents, family caregivers, and nursing staff? And with family caregivers, we mean relatives or the people who visit most. I think the most they were related. It could be a child, a spouse, a niece. We didn't put it in that, but the residents were able to choose. So what did we do? 26 nursing homes were selected by the local health authority, and we monitored how they applied this guideline. We used a mixed method approach, so we did an electronic survey across all these nursing homes, and we did a telephone interview. We received documentation, so for example, local protocols, but also letters the nursing home sent out to relatives, etc. And we set up a WhatsApp group for our contact person. So each nursing home had one representative, for example, a policy officer or a nurse or a manager, and they were in contact with us and participated in the study. And we collected data on visits, the context of the nursing home, the application of the national guidelines within the local context, compliance with the local protocol, and the well-being. And I would like to take you to the results. So after the first week of the visit, we saw that almost 1,000 residents actually received a visitor, and 21 locations specified that visitors were allowed for all residents living in their location. And only 5 locations specified that they only had a selection of residents were allowed. And some said, well, we have COVID at the moment at one ward, so that ward cannot have any visitors, but the other wards who are COVID-free, they are allowed visitors. Another nursing home said, well, we are only allowing visitors for those residents who need it. What needed is means they said that is a personal judgment based by the nursing home, but not everybody, for example. And then we saw that after the first week, only 6 locations had over 80% of their residents actually receiving visits. And the other locations in which in theory everybody could, weren't able to realize that. And in one nursing home, residents had more than one designated visitor. So that means that one nursing home already allowed that, for example, at one point the spouse came and another point in the week the child could come. The majority of the visits were in the resident's own room, and that was over half of the nursing homes had that. In addition to the own room, 8 locations had also a specifically designed room, which was not in a nursing home, but for example, put on the just outside, and which they could clean, for example, between visits. And one nursing home already let people walk outside, so people were able to walk outside. The average visit lasted about 1 hour, but that includes the preparation time. So when you look at the contact time, so the direct time between the visitor and their resident, was about 45 minutes. We see a lot of variation of guidelines within the local context. And I think the main differences were related to, for example, the use of protective mouth masks. 11 nursing homes of the 26 obliged all staff and visitors to wear such a mouth mask during their visit. Whereas others said, no, visitors only visitors need to put on a protective mouth mask, and only if they are visiting residents who have dementia and who are difficult to instruct. And later I come at the well-being. This has a huge impact because many family members felt it as unfair that they had to wear a protective mouth mask, whereas staff didn't wear these protective mouth masks. And they said, well, staff can also go in and out in a nursing home. They do grocery shopping, whatever. What's the difference between me and them? And that created like this disbalance. In 10 nursing homes, visits were unsupervised. So there the facility manager and the location manager specifically said, we close the door, we do not come in, we do not check whether people keep on their mask, we do not check whether they keep the distance or not, because it's their time and they should be able to do whatever they would like to. Whereas the others had some form of supervision. So for example, staff said, well, after 50 minutes, we enter, for example, bringing a cup of coffee or whatever, and we see what is happening and what's happening there. And in general, respondents indicated that visitors and staff were quite compliant with the local protocol guidelines. But when you look at it in practice, they say, well, deviations were observed. For example, that people do not wear their protective mouth mask during the whole visit, because if you give them a cup of coffee, you put down your mask and you drink your coffee, for example. And also respondents said, well, we know that physical contact did occur. For example, that people hugged each other. And they say, well, we found that so important because especially, for example, with people with dementia, the physical contact is such an important part of the visit. We let it, we close our eyes for it, and yeah, it's just the way it is. What about various facilitators? So there was a significant increase in workload for staff, which we was already discussed here, like preparing and organizing the visits, planning, informing the relatives and staff, putting measures into practice, the registration of everybody, the symptom checking, and some designated specific staff for these tasks. Whereas in others, it was other people who had to do it. They would like some evaluations after the visit. So they asked themselves as well, how did you feel about it? And there was also a question about the scarcity of these personal protective masks. And are we as a nursing home allowed to supply this, or should we oblige family caregivers to arrange this for themselves? then something about the impact on well-being. And I think all nursing homes were unanimously, so everybody said the same positive about the visits. And they say, well, it really has a positive influence. Drinking a cup of coffee, it seems a small step, but it feels like a giant emotional step. And they say that, and I think that's also general, that the family caregivers also said, well, this is much better than a screen between us, for example. And they say, well, a staff member cannot replace a family member. Since residents know they are looking forward, they were in a different mood, and we observe those well-being impacts. Family members and residents were in general very emotional when seeing each other after such a long time. So the ban was about for 2 months. And the personal visits, yeah, were seen as huge added value over these other solutions. But they say, well, it's difficult to understand each other with the screen, yeah, those kind of things. The physical contact with each other was missed, and also the opportunity to go outside was missed. And sometimes the residents didn't recognize their son anymore, right? So it had really a huge impact. And maybe this is also some anecdote which really struck me, was that nursing homes reported that residents said, well, this is worse than the war. So we had the World War II war, because they said, I felt better at that time because I was able to share my emotions with my loved ones, with my friends, and now I feel alone in what's happening. So regarding the COVID, no new COVID infections were reported 3 weeks after visitors were allowed. And to compare, over 700 new cases were reported in nursing homes during that same period of time in the rest of the Netherlands. So not in these 26 nursing homes where still the ban was in place. And we saw overall a decreasing national trend. Here are some numbers. So that is in line with in general. So to conclude, what I would like to, the first study to report on compliance, it was differently applied in the local context, and the compliance was sufficient to good. So based on our results, as of May 25th, all nursing homes are applying the national guideline. And I would like to take 2 minutes to see a follow-up 4 weeks later, because we did another survey including 76 nursing homes, so the 26 who were the first to use the guideline, and an additional 550 using the other guideline. And the thing which was changed was that in general we found similar results. So 68% of the residents has actually received from the first group a visitor, and they stayed very close to the national guideline. So for example, only 6% went out for a walk. And in a May 25th group, about 60% received the visitors, again, very emotional. And also these 76 nursing homes respondents feel really negative about the impact of the ban for visitors. They say we see a lot of loneliness. They report on effects of functioning of residents. It's all anecdotal, but people saying because of the loneliness, they decrease quite a lot in functional status. And we see that after 3 weeks, the family was really coming into play, saying we need expansion of the regulations. It is not workable working that only one visitor is allowed. We want with more visitors, because we cannot choose. Is it the spouse or is it the children? We need more flexibility in time and frequency. I don't want to visit only 1 time a week. I want to visit more often. And they wanted to go outside. And staff still experience that anxiety for an outbreak. And it was really like, okay, with bringing visitors in, there is this outbreak anxiety. And we saw maybe also difference between staff already experiencing COVID outbreaks, whereas homes which were completely free from symptoms. And we saw homes which were completely free of symptoms. They were quite scared that visitors would bring it in. There were concerns, and I think that it was also in the chat, about the staff with these long-term implementation of these guidelines, because it has such a high workload with this organization that they said, well, this is not feasible to do this kind of strict guideline, because it takes too much staff and takes too much time from other things. And what we see is that there are different regulations among nursing homes in a similar regions. So for example, with one nursing homes, family members were allowed to go outside, whereas in others it was not. And now, for example, we have one nursing home saying, okay, everybody can come in, and then the other one, it's still not. So families see that, and then they say to their own nursing home, why is this not possible? And the current situation is that as of June 15th, the national guidelines which we studied were less restrictive for example, more than one designated visitor is allowed, people are allowed to walk outside. And as of July 1st, all nursing homes are open as usual. So that means that the guideline is not necessary anymore. There's no ban, and each nursing home can now decide, okay, what do you think is feasible within your local context? But then again, that creates also some insecurities. And I think at the moment, the debate in the Netherlands is really about, weren't the measures too restrictive for too long of a period in time? When the ban was put in place, that was the best thing to be able to do given the circumstances at the moment. But now it's such a long period of time, and what is the impact, and why were nursing homes also lagging behind? So that's really the debate of, okay, do we need the infection prevention versus the quality of life? And I think our study really shows that the impact, is not to be misguided or so. Thank you for the ability to discuss our study, and I'm looking forward to discuss this with you.
Thank you very much. That's absolutely fascinating. And I have to say, I've never seen the chat box so busy in any of our previous webinars. So it's going to be quite a job to go through. May I just remind all of you that we have people taking part today from very different countries. So when you talk about the specific agency or a specific body, make sure you don't use acronyms so that people in other countries will also understand what you're mentioning. Before I open for questions, I'm just going to mention that the next webinar is going to be on the 20th of July, and we're going to be discussing a slightly different issue, which is on the impact of the COVID outbreak in the nursing home sector, and we're going to be looking at the role of ownership and whether it has or not played a role. It's been quite hotly debated, especially in the press, and it's, I think, a good moment to take a more, maybe a more analytical view of what's the situation. And this is going to be led by Florian Kruse and by Amy Tsu. So back to today's topic, just wondering how to start. And I think the first, I'm going to start with a question that's come up quite a bit, which is on the funding for these extra costs or extra staff demands to facilitate the visiting. And there's been quite a bit of debate on this, quite a bit of discussion, also of examples. And one of the issues that has come up is whether the voluntary sector could play a role in supporting care homes in facilitating visits in this context, particularly where there's already quite a lot of demands on staff and perhaps shortages. And I wonder if any of our speakers, perhaps Lee-Fay, if we come back to you, if you have some thoughts on this.
We have experience in having volunteers do quite a lot of important jobs in care homes, managing behavior in particular. I'm unsure about the extent to which we could rapidly recruit sufficient volunteers and train them to a sufficient standard to do this job. I think it would be feasible to do it if you could, if you had volunteers already recruited, depending on what other restrictions there were in the community, whether they were allowed to do that, you know, because it's not going to work. So whether it would be count as a reason to leave the home, for example. I don't know if you could do it fast enough, I guess. I don't think it's a solution, Adelina.
No,
I think some
I'm just asking, it's a question. And
some facilities could do it, but I don't think everyone can do it.
And I wanted to then open this up a little bit and see if among the people who may have experience of these or who may have tried these approaches, some of the voluntary sectors that associations that are represented in this call, whether any of you would like to share any of views or experiences on this. You can either chat or just unmute yourself and speak directly if you'd like to. Or if there's no relevant experiences, we can move on to another question. Give it a minute. And may I then move then to the, I can't see any comment. Okay, so the other thing that's been coming up is the issue of guidelines and how these have been sometimes delayed. And I'd like to again invite I'm just going to see who I may be able to. So we've seen in the chat box some guidelines being shared from Scotland. Is my understanding from those of you involved in care homes in the UK that we don't have official guidelines on this? And would any of you like to comment on the impact on that? Yeah,
I'd like to comment.
Sorry. Yeah, go ahead, Nikki.
Sorry.
Yeah.
I'm Director of Care with a trust with 2 homes for profound and multiple learning disabilities. So it's been quite difficult to actually assess some of the impact on the residents. The guidelines that we've had, I think one of the other people leaving a message said, the guidelines are from UK care organisations, but we've had nothing at all from our Department of Health and Social Care. And CQC, which is our governing regulatory body, is not particularly helping on that either at the moment. So the guidelines that we're following, fortunately, seem to be very aligned to everything that everybody's speaking about. But it's very difficult when the recommendation is that we follow some kind of guideline. It's also difficult for the families because we can't quote anything behind our decision making. Other than just saying we're following as much as we can possibly follow. So this particular webinar is going to be extremely helpful with that, because we're very, very aware of the impact of this on families.
Thank you very much. And Tim Benland, I think you had your hand up.
Oh, only just to share the shame of all the other people on the call who are from England that our government has not seen fit to issue guidance in the way that many other countries have. I'm aware that there is something currently sitting with the minister, which, to be honest, Alzheimer's Society we saw sight of several days ago now. But to be honest, I think the issue it probably won't help with this, something I'm very keen to talk about, which is testing. I don't know, Adelina, whether you want to move on to that, but
yeah, so testing's been coming up a lot on the chat box. I know it's also been very much debated in Canada, whether testing would need to be a requirement before visitors would be allowed in. And there's both arguments, and I'm going to now take my opportunity for my role of as chair moderator, say that there are arguments in favor and against using tests to determine, for example, who can visit in a care home, or to assess whether people are or not free of COVID. And of course, the argument against is that even if you test somebody and then you take 2 days to deliver the result, it might be that in between they've come in contact already, or that something's changed. So tests can give a false sense of security. And also, I was very interested that there was not much mention of using testing as a criteria in the Netherlands. And I think we need to also be aware of the role of testing when you have or not local cases of COVID. And whether this is something that we need as a regular policy, we keep testing everybody every week, or do we do it when we know we have local outbreaks? And of course, ideally, we'd want to have a system when we know when we have a local outbreaks, the local care homes know when there are cases in their areas, and then that triggers an extra level of vigilance testing and measures. And I also would like to emphasize that almost as important as testing, or perhaps even more, is having a good system of contact tracing. And I know in Germany, for example, all care home visitors need to give their details and allow to be give themselves, put themselves up to be contact traced, so that if they've been in contact with somebody who's got COVID, the care homes know immediately. So I'm now going to take a step back and open up for people to comment on testing. I'm going to invite Hilde first, if you'd like to comment on how testing has been taken in consideration in opening care homes in the Netherlands.
So yeah, that's a good question. I think it has been taken into account because also recently tests are available to the general public. So now everybody can let themselves have a test if you would like to. So it's also available for the nursing homes. But I think the debate is now more in the Netherlands, at least, on what is the impact of a ban on not letting visitors for the well-being of residents, and how, for example, also for residents who still have capacity. There are quite a few homes in which residents residents are still independent, still had capacity, and they were not allowed to go out. And I think those individuals sometimes are being overlooked. And also I know one nursing home organization, for example, within our area that was also on the national news. They say, we will never do a ban for visitors for our nursing home in general ever again, because it has been such a restrictive measure which does not outweigh to the benefits of it. At that point in time, it was good because it was necessary. We didn't know what was coming. But now we prepare and we know more. So we will always, for example, put individuals in quarantine, put the ward in quarantine, but look for other opportunities.
Thank you very much. I'd like to invite, I think somebody from Canada would like to comment on the use of testing in determining access to visits. And let me see, I think we had a couple of comments. I'm going to see who it came. Oh, it was from Crystal Nicoli. Yes, would you like to come in?
Okay, so I'm a family council chair in Oakville, Ontario, Canada. Testing here is mandatory every 2 weeks for family members that want to do a 1 weekly outdoor visit at the home. Because it takes so long to get test results back, we are now, our group, testing every week because it's open in Canada for everybody to be tested every week as often as they want. So we believe now, going back to the question of family member volunteers, we're actually tested more than the staff or residents are. The staff are only tested every 2 weeks. Residents haven't been tested, I don't know, in the last month, maybe 6 weeks. So we see ourselves as being able to provide that essential care because we're actually safer with full PPE and those type of things, particularly for the dementia residents. So that's what I found.
Thank you very much. We've got also another discussion happening in the box on who should be essential visitors and how to decide who's got to have priority in visiting. I'm going to invite Nathan Stoll to come in with your question discussion. I can see there's already some questions and answers happening, but would you like to come in?
Yes, can you see me, hear me?
Yes.
Thanks for having me and thanks for the webinar. Just to follow up on the testing, actually, we've heard there's lots of resistance. It's only actually a requirement in the province of Ontario. All other provinces in the country are not requiring testing as a condition of visitation. And the challenges, in addition to the sort of, there's been several issues in how this has been operationalized. One is that you can imagine there's equity issues for frail older adults who need to present to these COVID assessment visitor centers. It's hot right now. Many of the older adults are needing to wait outside, and we've heard older adult spouses who have fainted waiting for COVID-19 test results. The other thing that we have heard is that homes are actually asking people to present their personal health information as a condition of visitation, which is not in the guidelines as well. So there's been many issues with this, let alone whether it makes sense from an infection prevention and control perspective when you're talking about outdoor distance visits, which it probably doesn't. That being said, the question that I had that we're also struggling with here is how to differentiate and decide who is an essential family caregiver and who is there as sort of, and I don't want to minimize the importance of socialization, but as a sort of general visitor for socialization, and how do you define that, and whether have there been instances or are people concerned about people trying to sort of identify as a caregiver when they're not, for the purposes of securing increased access for visitation. Thanks very much.
Thank you. And I think I'm going to now come back to our speakers and see if you want to very quickly answer how that is done or decided in your countries and whether that is an issue. I know there's already been some in the chat box, so not everyone may have seen it. So Kathryn, would you like to come first?
Yeah, I mean, obviously I can only share from the carers that we're interviewing, so the relatives that we're interviewing, but actually all of them have actually, in the majority of the time, they've been very complimentary about care homes, and they absolutely understand that you're in a really difficult position than most care homes. So it's not about them complaining, but just understanding the complexity, but likewise wanting to get access. And actually what they found is that actually it's been quite easy for them. They're the main person. So the person that's been going in regularly, because the people we're interviewing, those that have been going on a regular basis, they're well known in the care home because they go at least 3 times a week, if not more, and they're there for 3, 4, 5 hours often. So they're really known to the care home anyway. And so the care home basically said, you know, we're allowing some visits, and we, as yet, we haven't come across the issue where only one person has been allowed, because actually we're quite early on here to opening up. It'll be interesting as we go on and collect data as to whether a different person from the family or somebody else might then want to say, well, I'd like to visit now. But so far, it hasn't actually come up as being an issue.
Thank you. Lee-Fay?
Yeah, so the Australian Code, which I put in the chat, says that residents who have a clearly established and regular pattern of involvement from visitors contributing to their care and support, with a bracket of what examples of this, must continue to have these visits facilitated. And what I've heard also is that those families who come and feed, or, you know, come regularly to help people dress or do their hair, that they're the ones who are getting more access.
Thank you. And Hilde?
Yeah, so I think we saw quite a big difference within the first week where the first visitors could come. Then one designated person was quite easily, it was the one who was visiting most often, who lived closest by. But after 3 to 4 weeks, we saw a change in attitude, because family was very understanding of all the measures to be taken, etc. But you see, just as within normal society in the Netherlands, that the COVID is going down, the questions are raising up, why can't I visit with my grandchildren? I want to visit as well, and why does it have to be one person? And there was really becoming more and more debate, I think.
Mm-hmm. Thank you. I'm going to bring up Zoe Fryer. If you're still on the call, I noticed something that was mentioned in the chat box by yourself about doing Zoom meetings with relatives and how that was helpful in terms of reassuring and reducing some of the anxieties. Would you like to quickly comment on that example?
Of course, no problem. So ever since the beginning, any decisions that have been made, we've done that with residents.
Could you quickly explain where you are and what your role is?
Sorry.
Yeah, sorry. No, it's okay.
So, yeah, so right. I actually own a small nursing home in West Sussex, Upper Beeding, in the UK. So ever since the beginning, we've been involved in all of our residents, relatives and staff in all decisions that are being made. I think the lack of government guidance has been incredibly difficult, but we've shared all the guidance that we've had with all of our key stakeholders. We've been having Zoom meetings with relatives, and they've been making the decisions alongside us, and they understand the decisions that are being made. In terms of residents, I think it's really difficult in terms of getting individual visits, etc. But we've actually done daily risk assessments on not only the needs of the residents as to how they benefit from Zoom meetings or Skypes or actual face-to-face visits, but also the mental health needs of our relatives, because sometimes actually that's more important than the residents, because they're really, really struggling. For those who can't do Skypes, etc., because the resident hasn't got capacity maybe, we're sending twice weekly photos to those relatives so that they know that their resident is safe. And we've actually now gone against the government guidance, but are purely allowing garden visits, and have come up with that policy with the residents and their relatives, and everybody is very happy because we've involved them every step of the way.
Thank you very much. We've got a few more minutes if anybody would like to share. I mean, I'd be very happy to hear more from those of you particularly working in care homes or who are relatives or family members. I don't know if we've got anybody who lives in a care home but who'd like to give some examples of what you think has worked well in your context.
Do you mind? I'm sorry, I'm there again. It's
okay, no problem.
UK. I think it's been really useful hearing everybody, you know, across the world are having the same issues, and we're struggling in the UK with getting policies and procedures developed. But if we're all having the same issues, then surely there could be some way that we can work together to have a generic policy and procedure for care homes for the issues that we're seeing. And I think a lot of the small providers are really struggling, because I'm the owner, I was a registered manager, I'm a nurse for 12 years. I've been looking at all the strategic side and getting all the relevant information and reading it, but other providers just haven't got the time to do that and haven't got the support from owners, directors of companies. And if there was guidance out there that could just be shared, that everybody could use, with templates, with policies, it just seems so simple to me, that would be the way forward, not just for the UK.
So it sounds like some sort of bringing together of the sharing of the guidelines and the things that have worked successfully would be very useful.
Absolutely.
And I think I may see whether within LTC COVID we can mobilize a team of people to look across examples of good practice, successful. And it's fantastic to even have some evidence from the Netherlands of where this has been done safely, with good outcomes, and also uncovering some of the negative consequences of having closed for so long. So I take that as an action from this webinar, and I'm going to have a look on, feel free to get in touch with me directly, or info@ltccovid.org if you'd like to contribute and be part of this. We're also on Twitter, and we'd be very happy to hear from you. Read your examples, both of at care home level, or examples if you have guidelines that are very good in your country or in your region. We'd be very interested to hear those. And I'm going to now bring this to a close. We're on the last 3 minutes, but please, I think the chat also is becoming a fantastic resource. We have recorded this webinar. We're going to keep track of everything that's been shared and all the guidelines that have been shared on the chat. Thank you so much for all the very, very fast sharing of information that's happened today. And I'm just going to end by saying very quickly that, having looked at lots of different aspects of policy that have been taken to try to reduce the risk of infection and protect care homes, what's become very clear is that this measure of closing care homes to visitors is a very easy one to implement. So it's very easy to say, all care homes, ban visitors, that's it. But we haven't seen that that's really helped very much in terms of reducing infections. In fact, the evidence from the Netherlands suggests that opening up hasn't increased the rate of infection. And we have seen that other issues that were addressed much later by policy and measures, like discharges from hospital, or even the exposures of staff, and maybe staff working across different settings, were much higher risk. So I think it's very important that we learn from this, that we are very careful going forward on taking measures that have a very negative impact on the people who live in care homes and on their families, that may not necessarily be what the evidence is showing that we need to adopt. So I think this is definitely something we need to be looking for. At LTC COVID, we look always for evidence, and we try to support sharing of evidence. So if you know of any study that can also help support this, please let us know. So thanks again. As I said, the next webinar is the 20th of July. It's looking at the role of ownership. We're very happy to hear about other proposals for topics. And if you think of a group of people from different countries who may want to come and share perspectives on a different topic, we'd be delighted to hear. So in about 2-3 days, we should have this recording on LTC COVID, as well as all the slides, and we'll try to keep a record of all these examples of guidelines that you're sharing, and see if a group of us can volunteer to put together a summary. Thanks again, and enjoy the rest of your day, your night. Especially thanks to Lee-Fay, because we know it's very late for you, and we really appreciate you staying up for us. Thanks, everybody. Bye.